Assalamu alaikum. I'm Momo Arai. I'm a fourth year medical student, and I'm really glad to be giving you this lecture today. It's part two of the integrated control of CVP, cardiophysiology. And I know you have a TBL tomorrow and so on, so inshallah, it won't take long. Like if it's two very simple concepts. Part one had a lot about baroreceptors, so we'll try to recap a bit on that. But feel free to stop me anytime, okay? So I'll start. So just to recap from the last lecture, because you need to know the basics, right? To continue to like learn about this lecture. So here are some questions. I have all the answers in my notes, but can anyone tell me what's the main trigger for a baroreceptor reflex? Like what's the thing that stimulates baroreceptor reflex to work or to not work? You can type in the chat or unmute, I don't mind. Okay, good. Pressure. So the mean, to be specific, yeah, you're right. So to be specific, mean arterial pressure is one of the main triggers of baroreceptor reflex. So if mean arterial pressure, right, increases, what does that do? Does it result in more sympathetic action or parasympathetic action? Yeah, good. So para. Now, if MAP is less, the mean arterial pressure is less. Good job. If it's less, then it's which one? The opposite, right? Sympathetic. Now I hope like it's good that you guys understand this. So this will help you understand Valsalva maneuver, which is our first topic. Okay. So again, mean arterial pressure increases, which causes parasympathetic to like be more in the body, which tries to decrease MAP by decreasing heart rate and so on, right? And then for the sympathetic opposite, so you try everything to keep MAP up to normal. That's all you need to know to like understand this lecture, okay? Now moving on, we have two topics like I mentioned, Valsalva and shock. So Valsalva is it's like changes that occur during like a maneuver. So these slides I copied them from your lecture because but then I'll also like draw it out for you so that it's easier, right? So first, do you guys know what a Valsalva maneuver is? Like I'll explain it and it's on the slide, but okay, I'll explain it and then tell me if you got it or not. So Valsalva maneuver is so when someone takes a deep breath, right, keeps it in, and they try to exhale that against a closed mouth. So they're not exhaling it, right? They're just keeping it inside, but blowing it out. And for a long time with the glottis closed, as you guys can see here. Now, this happens during things like, did you guys get the mechanism? So like this happens during childbirth, for example, when the woman is trying to push the baby out, right? So she tries to breathe against a closed mouth and tries to push it outside, tries to push the baby outside. Even when heavy lifting, when people are carrying heavy weights, they won't exhale the air, they'll keep it inside. And again, same in defecation too. So when someone is trying to pass stool, that's what they do. Do you guys get the mechanism in general? Like, should I move on? Okay, good. So that's the Valsalva maneuver. The main idea of Valsalva maneuver that you guys have to understand is the changes in aortic pressure and heart rate. Now these change accordingly, and the main like player here is baroreceptor reflex, as you guys can see here. Mainly in you'll see this later. So there are 4 phases in Valsalva maneuver. You have so when you start Valsalva, you have phase 1. If you continue to hold your breath for a long time, you go to phase 2, and then once you release you open your mouth to release the air, you go into phase 3, and then phase 4. Okay, so that's those are the 4 phases. In phase 4, you will see that if phase 4 happens, that means your baroreceptor reflex is working. That's what I want you to know, and I'll keep repeating this again. You'll see it now in the coming slides. Okay, so phase 1, we'll start with phase 1. I'll go to this slide so we can start kind of like drawing the phases out. So we have 1, right? We have 2, we have 3, we have 4. In phase one, again, you're trying to take a deep breath inside and you're keeping it inside. So what that does is the lungs kind of expand and it compresses your aorta, which is your big artery between the lungs. So behind and between the lungs. So this aorta is compressed, right? So what happens to the MAP, or the mean arterial pressure, if you compress a vessel a lot? Does it increase or decrease? So here you're breathing in. Yeah. So good job. Increase, increase. So if you're breathing in, your lungs are expanding, compressing the aorta. That's what I want you to remember. And this will help you understand what happens. So MAP, because of this compression, increases, right? Now, if MAP increases, remember baroreceptor reflex, what happens to, so we're comparing heart rate and MAP. So what happens to heart rate as a result of baroreceptor? So baroreceptor will do everything to bring it down, bring MAP down to normal, right? So baroreceptor will act, more parasympathetic will act to, what happens to the heart rate? To decrease the MAP? Yeah, decrease. So it's the opposite. Main idea in Valsalva maneuver is that MAP and heart rate in all of the phases are opposite. Okay, we'll see how that happens. So first phase, MAP increases because compression of aorta, right? And then that stimulates baroreceptor reflex to release parasympathetic, which tries to do everything to keep your MAP down, and that's why heart rate, stroke volume, everything decreases, right? So that's phase one. You can see from the graph, I'll relate it to the graph so you guys can understand. Phase one, you have increase in MAP or aortic pressure, right? Because your aorta is compressed by the high intrathoracic pressure of the lungs. Now, heart rate, because of that, decreases because of baroreceptor reflex. It's a reflex you all know now by now. Now phase two, let's go to phase two. Because of this decrease in heart rate here, right? What happens to MAP now because of this? Because of this reflex. Now it's not increasing anymore, right? It's decreasing. Does that make sense? Okay, good. So baroreceptor reflex in phase one makes heart rate go down. That continues, like you're still holding your breath in. That continues onto phase two. Your MAP decreases because of baroreceptor, like because of the after effect of baroreceptor. And then you'll see here on phase two, um, because of, again, high intrathoracic pressure, because of baroreceptor, because of this, you have decrease in venous return, stroke volume, everything to try to keep pressure down. So that's what makes MAP drop. Okay, that's phase two here. Now in phase two, we are in phase two now, right? MAP decreases as a result of heart rate decrease from phase one. What happens to the heart rate now because of MAP decrease? Like it's the opposite. It goes up, yeah. So heart rate goes up. Now, again, like that means because MAP is coming down now, the heart rate doesn't need to decrease any further. It increases. It does the opposite. So here, as MAP is coming down, 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 the heart rate increases to stop this drop in MAP. So that's why MAP and heart rate becomes a constant level at one point. So that's phase one and phase two. You can feel your heart like beating faster the more you hold your breath in, right? Because your lungs are trying to get more air. So that's this part. Like you can feel your heart rate going up. So again, phase two, MAP decreases, heart rate goes up, and then now it's at a constant at the end of phase two. Here at the end of phase two. Does that make sense so far? Like, is it clear? Main idea, just know that they're like opposite, but understand the mechanisms. Okay, good. So again, we'll go into phase three. Now, phase three, we said that you're starting to release or exhale air, right? Here you see a small kind of like a dip, right, in mean arterial pressure and an increase in heart rate. Now we have to understand why. Remember what we said in phase one? We said that the aorta is compressed because you're breathing in very much. In phase three, it's the opposite. So now you're exhaling air out, that means your aorta is kind of decompressed. So it goes from compressed to a lot more dilated, like that. So what does that happen? Like, what's the immediate effect on MAP now because of this decompression? Decrease. Yeah, good. So even though in phase 2, MAP was less, heart rate was more, and it was at a constant, right? Because you're exhaling now, you're doing something new, and the aorta is not even compressed anymore. Like, you don't have that much pressure. So this like quick decompression kind of decreases the MAP. So your pressure goes down. Again, your baroreceptor picks it up, and what happens to your heart rate now? So it takes phase 3 separate from phase 2. So what happens to your heart rate? Because of less MAP, your body tries to increase MAP, right? How does it do that? By increasing or decreasing heart rate? Okay, good. So yeah, based on phase 3, since MAP is decreasing way more, heart rate increases. Good. So you see everything's opposite. So here, phase 3 happens very quickly because you're breathing out, right? And your aorta is now like it goes like that very quickly. So that's why MAP is less, heart rate increases in response to that. Now, phase 4, once everything is going back to normal, right? Because of, again, this heart rate increase, here, here in phase 4, heart rate increase. This rapid rise in heart rate increase kind of increases the MAP back up again. So in phase 4 here, MAP, again, it's the same thing. So you go from phase to phase. So MAP is now more. So what happens as a result of this increase in MAP through baroreceptor to the heart rate? So now you have increased MAP, right? So your baroreceptor, your body is trying to bring it down by parasympathetic, so heart rate decreases. Does that make sense? Like, do all these phases make sense? Okay, good. I hope it's clear to everyone else too. If it's not, I can repeat again. So let's recap if you want. So at the beginning, your aorta, when you're breathing in, aorta compressed, right? MAP mean pressure is high, which leads to decrease in heart rate here, decrease in heart rate. Second phase, your decrease in heart rate causes everything else to decrease, which brings down MAP in phase 2. Phase 2, decrease in MAP, increase in heart rate, and then it keeps it constant. Phase 3, you're breathing out now. It's a different kind of phase. You're going into another step. Because of the breathing out, your aorta is decompressed, then MAP falls. Because now it's very loose, MAP falls, heart rate increases even further. You see here, it's a new like level. Then, as you continue breathing out, everything's coming back to normal. Because of this heart rate increase, again, you can see here, MAP increases because blood is coming back because of the baroreceptor, MAP increases and heart rate decreases again. So this step, remember what I said about phase 4? So if someone's phase 4 is working, if someone's heart rate decreases at the end of the Valsalva maneuver, that means that their baroreceptor reflex is working, right? Because you can't, like, actually all of these need baroreceptor reflex. So someone who without an intact baroreceptor reflex won't have these changes in heart rate, right? So that's the main idea. Is everything clear up to this point? This is the last slide on Valsalva maneuver, by the way, so it's good if you got that. Okay, I hope that's clear. I'll keep this when I send it to you in case it helps. And we'll move on to a Valsalva maneuver in heart failure. So heart failure, you have your heart is already not working anymore, right? You have a compromised heart. That's why any increase in MAP, like increase in cardiac work, so all these increases in MAP you see, they could that means your heart is beating faster, your heart is beating slower. It's not good for the heart, because especially if the heart is already like damaged. It's not going to work as much, right, to kind of compensate for these changes. So that's why, especially you can see, especially during phase 1 and phase 4, when MAP is high, that increases kind of the work of the heart, which you don't want in heart failure patients. So this higher force or higher afterload can lead to ischemia and heart attack. So patients who have or people who are suffering from heart failure, heart diseases, Valsalva maneuver can be very deadly, and it's very dangerous. Again, they must prevent Valsalva maneuver. Example, they must prevent constipation, right? Remember how I said before in the first slide that defecation is one of the is one of the situations where Valsalva is used, because you're keeping air in and you're trying to strain, right? So that's why here um, heart failure patients must prevent constipation, prevent anything that makes them even cough, like not coughing, but a lot of coughing maybe, or weightlifting, for example. They should prevent that. Now, chronic constipation is when you use Valsalva again. This can lead sometimes to hemorrhoids also. So heart failure patients should not do Valsalva, should prevent constipation, because constipation can lead to heart failure if they're already have a bad heart, or in normal cases they can also lead to hemorrhoids. So normal people, if they have a lot of constipation, which means like they're not able to pass stool very easily, they will strain a lot, right, on their abdomen. So that means you're using Valsalva maneuver a lot, which increases pressure on your veins in the rectum, which causes bleeding. So you'll have bleeding with stool here. So that's what hemorrhoids mean. Bleeding with stool from rectum. Again, weightlifting, you're supposed to prevent Valsalva, right? It's not good to keep it too long, like in constipation and so on. And that's why exhaling is very important. And you try to prevent that in heart patients. Is everything clear so far? Because we'll stop here, right, before we move on to shock. But is it clear for everyone here? Okay, I hope it is, inshallah. Okay, good. So I'm glad you guys are getting it, because Valsalva, we never used to have it in our in my first year. Like it was never taught to us like that. So good job. So checkpoint will try to answer this question. I just explained it. But what is true in the normal phase 4 of the Valsalva maneuver? A, B, C, D. Just give me an answer from you. Main thing is changes in heart rate and okay. Okay, good job. Yeah, there's only three, I think, but it's fine. Yeah, but so I hope that's clear for everyone, like watching the recording as well. But yeah, B is the correct answer, and heart rate is decreased in response to increased MAP. If we go back here, right? So it's good that you guys got that, and that's a proof of your baroreceptor working very well. So the correct answer here is B. Now we'll move on to the second topic of this lecture. It's a very important concept, which is shock. Shock in cardiovascular system generally means that you have inadequate blood flow, or not enough blood going to all your organs. So generally you can say not enough, right? Not enough, in simple terms, not enough blood, or not enough MAP. So less MAP, less mean arterial pressure to keep it going to all your organs. That's what shock generally means. Now, shock can be due to a lot of things, right? In the cardiovascular system, we have blood vessels, we have heart, we have the blood itself. So these three components, they kind of result, if any of them are not working, they go into shock. So first reason is, you guys can see here, inadequate blood volume. So having not enough blood volume will lead to shock, because that means you're going back to this definition. It means you're not having enough blood. So not inadequate blood volume can be from hemorrhage, hemorrhage means massive bleeding due to car accidents, due to fractures, things like that. You can even have less blood volume in your body from dehydration. Because dehydration is basically the water in your body. So if you have less water and you have bleeding, which means a lot of blood loss, that means you have not enough blood volume. That's your first reason. Second reason is that your heart is not working, which means inadequate cardiac function. So first, blood volume, not enough. The heart, and then the second one is the heart not pumping good enough. So that means you have decreased cardiac output, which means, again, it goes back to the definition here, not enough blood for your organs. So that's your second one. Third reason is vascular tone of blood vessels. Main reason is blood vessels. So we said first, blood volume again, and then second, the heart, the pump itself is not working. Third, the one in between them, between these two, is blood vessels. So blood vessels, so imagine a blood vessel is like that, right? If there is less tone, here it says inappropriate tone, that means less tone means less constriction of smooth muscle. Less smooth muscle constriction. That means that the blood vessels are not constricted, they're dilated like that. They're very, very big. So from here to here. So decrease in tone means decrease in contraction, keeping the blood vessels closed, so they're open, very dilated. So that means you're not giving, so you can go, this can also go back to this definition by saying that there's not enough blood going forward to the organs because you actually need a good like tone or sympathetic constriction to keep the blood going. Because of this dilation, the blood just stays here and it does not move, like it doesn't provide enough. Even though it holds a lot of volume, right? It's not the same as like you need a good tone for the blood to keep moving, okay? Um, so those three are the reasons. Again, like I said, blood volume, cardiac function, I'm going to keep repeating, and blood vessels. Blood vessel tone, specifically. So dilation. If you have a lot of, if you don't have enough tone for the blood to keep going. Now, these three causes can be divided into these five like further causes, but they're the same idea from the three causes. So first you have hypovolemic or hypovolemia, which means, again, from the name, less blood volume. So that's your first reason here. That's your first reason, volume. Second reason, like I said, cardiogenic, which means the heart is not working, the pump is not working itself. So that's your second reason. We already discussed it up. Then the third reason is all of these three, right? But they're different kinds of shock. So they're like the causes, how they start is very different. So let's start with the easiest one, neurogenic. That means your nerves are not working, right? So nerves, in another terms, is sympathetic. So sympathetic is not working to keep the vessels constricted. So that means that neurogenic means that nerves are not working, the vessels are dilated because there's nothing trying to keep them going, right? Mainly sympathetic, not working. Okay, or overactivation of parasympathetic, let's say, but in rare cases, because if parasympathetic is more, that means dilation. Now, septic and anaphylactic. Anaphylactic, we can say from the word, from the letter A, you can remember it as for allergies or allergic reactions. So allergic reactions, for example, someone is exposed to drugs, like medication, food that they're allergic to, right? You will see like on their bodies, like they have, it's like swelling, redness, right? So that's a result of blood vessel dilation. So blood vessels, like they dilate in these areas of your body on the skin, right? To try to like because it's a reaction against the allergic reaction to try to fight off the allergy. So that's why you see edema, you see swelling, you see redness, you see pain, right, on allergic skin. So that means your vessels are vasodilated. So that's why your skin, like they get red because of that. Vasodilate here, also vasodilation. Now septic is another, like it has another cause. So it's mainly due to bacterial infection. So bacteria, let's say some bacteria, they release toxins, right? So toxins and everything, chemicals in general, they disrupt the tone of the vessel. So they disrupt smooth muscles, they can disrupt nerves, and they can cause they can cause something called septic shock. So someone who goes into septic shock is very, very deadly, and you don't want that to happen. So septic shock, again, the same thing, vasodilation happens. Okay, so three main reasons is hypovolemic shock, cardiogenic shock, and all these other reasons, septic, anaphylactic, neurogenic, are something to do with the blood vessels. So they're not constricted very well, they're dilated, not allowing the blood to go through your body, right? And they all come to this definition. Is everything clear, like the causes here? Because we'll move on to hypovolemic and cardiogenic mainly. Is everything clear so far? Feel free to stop me, okay, whenever you want. Okay, I hope it's clear, inshallah. Now we'll start with the first cause, hypovolemic shock, which means not enough blood volume, not enough blood, like water in the blood. So hemorrhage is an example. So you can see here, this is the definition: reduction in blood supply itself, blood volume. This can happen due to a lot of reasons. Remember, like I said, hemorrhage, which means blood loss, right? Or dehydration, again, you don't have enough water in your blood, so not enough blood volume. You can also lose water by diarrhea, vomiting, because you're like throwing up all the fluids, you're losing all the fluids, right? And then burns also, because burns affect your skin, right? So they damage your skin, which is a barrier between your fluids and the outside, the environment. So once it damages your skin, all the fluids, all like waters, like salt, everything goes out, because now your skin is not protecting your vessels anymore. It just pours away, right? So that's why in burn patients it's very important you give them fluids. You have to give them like salt, saline, to keep their blood volume like okay. So these are the reasons why someone can have hypovolemic shock, which means less blood volume in general. Now we can go into three different subcategories of shock. Like this compensated, we have compensated, decompensated, and irreversible. Now this is separate from hypovolemic. So hypovolemic can undergo, if someone has hypovolemic shock, they can go into compensated, then decompensated, then irreversible shock. So like that. So compensated, from the name, that means your body is compensating for the loss in blood, like not enough blood, right? So if blood losses are 10 to 20%, it's not as much, right? So you have mechanisms in your body to keep it going. So with blood losses, the main thing that occurs is mean arterial pressure decrease. Every concept revolves around MAP in CVP, by the way. So it's good to know that. So blood losses, again, you don't have enough volume, which causes decrease in MAP. This triggers sympathetic reflex in your body to keep MAP up, right? To keep it normal. So you have increased heart rate, increased contractility, increased resistance, which means again vasoconstriction because of sympathetic. So vasoconstriction. Sorry, yeah, both of these are vasoconstriction. So increased resistance, decreased compliance mean the same thing. Venous compliance, yeah. So they're both being like constricted so that the blood can go through and keep your MAP up to normal. Now, the main idea of compensated shock is that you normalize MAP, right? So if someone goes into shock, but their MAP is kept constant, then that means they're in a compensated shock of hypovolemia, let's say. So they're in a compensated shock. So as long as your MAP is fine, you're compensated, like it's fine. Other than that, for example, cardiac output, stroke volume, they may still be depressed. They can still be less. It doesn't have to be normal, right? So they can still be less because to begin with, your your body has less blood volume. There's a limit to how much you can increase them up, right? So cardiac output, stroke volume can be depressed, can be normal, but it's fine. Even if it's depressed, it's fine. Your main concern is MAP. If it's normal, that means your body is compensating through all these mechanisms. Okay. Now, the opposite of this. So if the shock keeps getting worse, um, if the shock keeps getting worse, if you still lose volumes and they don't give you fluids, you can see here, like fluids must be given, right? Even if you're into compensated shock. If fluids are not given, if the shock is getting worse, if you're losing more volume and like your heart is failing, right? All these mechanisms cannot keep up anymore, like all these four cannot keep up, then that means you go into decompensated shock. That means your MAP is now not normal, like it's like not kept normal anymore, it's decreasing. Your body can't keep it up. So that results in your cells not getting enough oxygen, not getting enough blood to begin with, and then that means that the cells undergo ischemia. Ischemia means you have less oxygen, less blood, and they go into cell death, right? So this means your body now is decompensated. You will see all these like symptoms. So someone, like a person, will be hypotension, which means, again, remember what I said about the pressure. Hypotension means you have less blood pressure, so less MAP. Hypotension. And dyspnea, shortness of breath, because you're trying to breathe more oxygen for your cells, which are dying. So you're trying to breathe faster, right? You can also have acidosis because so ischemia means your cells are dying and they kind of release like all waste materials like carbon dioxide, lactic acid, like all these acidic products, and you can't remove them away because now your body is failing. It can't remove and supply oxygen, right? So your body goes into acidosis, less blood pressure, and you can also have cool, pale skin and mental confusion. Now, again, decompensated shock means less MAP, like not normalized MAP, which means you have less blood flow to your skin. That's why your skin becomes cool and pale, and then less blood flow to your brain. So that means less blood flow to your brain results in mental confusion. So yeah, like your brain is not even to like able to function as much. Is that all clear? So we have compensated for MAP is kept constant through all of these mechanisms. Decompensated means it's not being constant, it's getting worse, and you have all these symptoms, right? Now, irreversible. So here in decompensated, if you give fluids, if you manage them in the hospital, you can still reverse it. Like you can still treat the person from the shock. But if the shock keeps getting worse from decompensated and you're not giving them enough like treatments, they go into irreversible shock. Irreversible shock means that no matter like what, like no matter fluids you give or no matter fluids you give or no matter how much the body is trying to compensate, it can't go back to normal. So your end result for an irreversible shock is organ damage and death. So all these systems fail and the person will die. Like there's no way you can prevent that. And that happens when blood loss is greater than 20. So it's a lot of blood volume that's lost and there's no way you can get it back because now your heart is failing, your brain is like also not having enough blood for a long time, so you can't do anything about it. So we have to like summarize, we have compensated shock, MAP is fine. Decompensated, your body is failing, but you can still reverse it. Irreversible shock is you can't reverse it. And that happens with a lot of loss. Now we talked about hypovolemic shock before this, right? Yeah, here. So hypovolemic, less blood volume due to blood loss, things like that. Now we'll move on to the second shock for this for this lecture, which is cardiogenic. Cardiogenic, from the name, the heart, the pump is not working enough. It's an inability of the ventricles to pump blood. Now you can categorize cardiogenic shock into left heart failure. You know the chambers of the heart, right? So you have left heart failure, right heart failure, systolic dysfunction, diastolic dysfunction. So we'll go into more of that later. But first, so it's these two concepts, and then we're like this lecture is done. So first, I want to focus more on left-sided and right-sided heart failure. This is very important to understand because like in an emergency setting, you want to know like what to treat, right, from the symptoms. So instead of going and reading the symptoms, we'll try to draw it out first very quickly and then go read the symptoms, right? So we have, okay, imagine this is the heart, and then this is left ventricle, this is left atrium. This is for the right Yeah, this is so bad. But okay, right ventricle, right atrium. You get the four chambers. That's what I mean. Now, this is left heart failure, and this is right heart failure. So left heart failure means that your left ventricle is not working. Okay, so I want you to follow with me here so that you can understand why it happens. So left ventricle is not working. Right heart failure means right ventricle is not working because ventricles are supposed to pump blood, right? So if left ventricle is not working, that means your blood is not being pumped enough outside to your body, so your blood pools here in the left ventricle. So your end diastolic, like volume increases, everything increases. So when blood can't move forward, it just pools, like it stays where it can. So left ventricle that is now pooled with blood, right? So this kind of, if it gets worse, it goes back up. So if blood can't move forward, it stays. If it's worse, it goes backflow, like it goes back where it can. So left ventricle is now filled with blood. It goes backflow into the left atrium. Now left atrium is also affected, and this can cause left atrial enlargement. So left atrium, now filled with blood, will undergo, like it will become larger to make up for the space, right? So if this gets worse, the blood will backflow into your lungs because that's what's connecting your right from your left. So so this backflow of blood goes back into the lungs in pulmonary veins and then pulmonary artery, and then sometimes it can go backflow into right ventricle because that's where it comes from. Okay, so again, backflow of blood in the left ventricle goes to the left atrium, backflows in the pulmonary vessels, and that's why you have, so imagine this is the pulmonary, right, vessels, this is the vein, this is the artery, we're going back, right, we're going backflow. So all of this blood that's pooling in from the heart because of not being pumped out, this increases the hydrostatic pressure of pulmonary vessels. So you have more blood basically in the pulmonary arteries and veins. That means you have more hydrostatic pressure due to Starling forces. You have more filtration. So here all the blood goes out in the pulmonary side in the lungs. So this is called edema, right? As you guys know, edema, but in the lungs. So that's why it's called pulmonary edema. So we came up with a lot of symptoms, right? Because of left heart failure, you can have left atrial enlargement, you can have pulmonary edema. Pulmonary edema in symptom-wise, you can have shortness of breath, cough, fatigue, all those, because you're trying to breathe in and your heart is not pumping out enough oxygen. Because of, okay, pulmonary edema is main symptom of left heart failure that differentiates from right, because the right, it doesn't affect the lungs, doesn't affect the left side, because if the blood is pooling in the right ventricle, it will just go back where it came from, not forward, not to the left side or to the lungs. It won't go up to the lungs, I mean. Okay, so let's focus on the left side. So if left side again is failing, you have all these symptoms. Sometimes it can, if it's worse, it can go back to the right ventricle and can cause right heart failure. Because if it goes from the lungs to the right ventricle again back here, that means your right ventricle is now failing also, and it can cause right heart failure. Let's go back to the symptoms again, and we'll see if you can follow here. So left-sided heart failure due to failure of left ventricle can be systolic, can be diastolic. We'll come to this later. It's another classification. So okay, these are the symptoms that are important. So left-sided heart failure, heart is not pumping very well, so you have less cardiac output. That's correct because your heart is not pumping, so that means your cardiac output is less. Now, let's go to the lung symptoms. You have increased pulmonary volume. We said here that pulmonary volume does increase. Like the blood in the vessels increase because of this huge backflow that we get from left side. And it stays here. Okay, so increase in pulmonary volume, and then that causes increase in pulmonary capillary hydrostatic pressure, like we said here, right? Here, because of this huge amount of blood, which causes pulmonary edema due to more filtration, due to a lot of filtration in the pulmonary side. And you have, we'll go back to the heart, left atrial enlargement. Like we said here, left atrium is not used to this, like a lot of blood, so it kind of dilates and enlarges. And then sometimes it can cause right heart failure because the blood pools, sometimes if it's worse, it can go back to the right side from the lungs, through the lungs. So that's why right side can also fail and can cause right heart failure. So left-sided heart failure can cause right-sided, but right-sided cannot cause left-sided. It does go back, but like for example, oh sorry, so for example, oh, okay. We'll draw it again, it's fine. So left-sided here, I'll draw the right side only. But left-sided again causes right-sided heart failure, but right-sided, even though it goes back from all the way back like this, it doesn't, it's very rare to cause left heart failure because it's already like a very far, like it's a very far away place. So so we finished with left, okay? Now the right side, okay, right side is here, right ventricle. So right-sided heart failure means right ventricle is not working. So now the blood will do the same process. So the blood is now pooling here, right? The blood is pooling here. Sometimes it can go up to right atrium. So you have now right atrial enlargement because of the huge amount of blood now. Now we're talking about the right side. So this, because it's on the right side already, it doesn't go forward to the lungs, it doesn't go to the left side. So you don't have symptoms of pulmonary edema, you don't have shortness of breath, not a lot of times, right? Because it's not affecting that side. Now you have, again, blood is pooling right ventricle, right atrium, and then what comes before right atrium? The two vena cavas, superior vena cava and inferior vena cava. Now, if blood pools in the superior vena cava, symptom-wise, what would happen is your jugular veins, which are the veins in your neck, will be distended. So because of the blood pooling, right, in the veins, your jugular veins, which are in your neck, will be like you can see it on a patient because usually you can't see the veins, right? But in patients with right heart failure, JVP, jugular venous pressure, will be high. They will kind of pop out of the neck, like they will be pulsating. That's for superior vena cava side. So it can also backflow more likely in the inferior vena cava because it's going down. So the first organ it has is the liver, right? It will pool, like the blood will pool in the liver and then go down to the legs. So now in the legs, same idea as the pulmonary side for the left side. Now we have vessels in the systemic circulation, which because of this pooling again, right, in the legs, you have increased hydrostatic pressure of the capillaries. So increase in blood makes them filter out. All of it because of Starling forces filter out. So Starling forces, you have a lot of blood again in the capillaries and they filter out. Now you have here, since lymphatics can't keep up with this, you can have edema again here. So edema now is peripheral edema, because now you have edema in both of your legs, right? In the left side, it was in the lungs, so we called it pulmonary edema, and you have shortness of breath and so on. Here in the right side, since it's in the legs, your legs, both of your legs of the patient will be swelling, will be swollen, I mean, and you can see it on the patient, as well as JVP, like the veins in your neck, and liver. So what happens to the liver? You can imagine like liver is an organ, right? But still, it has blood vessels inside, and it kind of like, if it's having too much, the liver itself can be congested, so it will enlarge. So that's enlargement of the liver. We call it hepato from the name liver, hepatomegaly. So enlargement of the liver. So you have, again, right-sided has a lot more symptoms. You have peripheral edema, hepatomegaly, right atrial enlargement, right, and JVP. For the left-sided, we said we had, so if left was not working, we had lung symptoms more because of this. So we had pulmonary edema and left atrial enlargement. So I'll just draw it so I can compare it. So usually we don't have right-sided, though sometimes it can cause right-sided heart failure if it's very bad, if it goes back all the way here. Okay, Now, let's go to the right-sided. We discussed all of these symptoms. Right-sided heart failure due to failure of the right ventricle. It's not pumping very well. This leads to decrease, let's go from here, less cardiac output because it's not going in the left side to begin with. So blood is not going to all of your body. So less cardiac output, less left, right? Left side does not have anything now. Even pulmonary volume is less because it's not going to the lungs, it's not going to the left side. And again, less cardiac output. Now, systemic side, because right ventricular is closer to that side of like systemic side, so it goes to the legs, liver, and all. So we have increase in systemic capillary hydrostatic pressure, like we saw here. So because of this hydrostatic pressure in increase in systemic capillaries, which is in the legs, in the periphery, anywhere, that means you have peripheral edema. So these are connected. Peripheral edema in the legs. You can also have right atrial enlargement, like we mentioned, because it pulls back. And then you can also have elevated JVP. So JVP is jugular venous pressure, which is your vein in your neck. You can see it here. So it does increase with pressure because of backflow. I hope that was clear. If you have any questions, let me know, because this is, yeah, okay, these two are like the last side, but the main important thing I want you to get is how to differentiate left-sided from right-sided heart failure. Just remember like all these like why it happens and the symptoms, so you can differentiate. Now we'll move on to systolic and diastolic dysfunction. So systolic means, from the name, the heart is not able to contract. Diastolic, the heart is not able to relax. That's it. So it could be left or right, it could be left or right. That's fine. And then we have you kind of have to know which one causes which dysfunction, right? So causes of systolic dysfunction means that your heart is not able to contract. So heart is not able to contract can happen due to reduced contractility. That makes sense. That's the exact reason. Like you can see it here. So less contractility of the heart causes systolic dysfunction. So that means you have myocardial, because due to myocardial infarction, heart attacks, your muscle is not able to contract. So that's reduced contractility. Second thing is if you have increased afterload. So increased afterload, for example, so I want to erase this, but okay. So increased afterload. So imagine this is the aorta, right? So if you have increased forces, increased MAP against the blood flow from the heart, your heart has to work more, like a lot more, to overcome this afterload. So that's why it can't pump very very greatly. So that's a systolic dysfunction because it can't pump against this high MAPs, against this high pressure. So increased afterload due to aortic stenosis. So if you have aortic stenosis here, for example, it's very narrowed valve, so the blood is not able to go through it very well. So that's systolic dysfunction, right? So increased afterload is one of the reasons. Now, third reason is if you have hypertension. Hypertension from the name is increased MAP, like increased blood pressure in your body, in your whole body. So remember here, like I said, how increase in aortic pressure, aortic valve stenosis, each of these causes systolic dysfunction. So against all of these forces, against hypertension, stenosis, your heart is not able to pump. So you have systolic dysfunction. Let's go into diastolic. Diastolic means you have less ability to relax, right? So in what cases does the heart have trouble relaxing? When you have reduced ventricular compliance. So let's break it down. Reduced ventricular compliance means, okay, so imagine this is the heart. Reduced left ventricular compliance, let's say. So that means your heart is not able to expand as much. It has less space here. Imagine the space is only this much. So that can be caused by concentric hypertrophy, which means like thickness of all this muscle, right? So thickness of the muscle causes less space, less compliance, so the heart is not able to relax or take in the blood volume as before. So that's diastolic heart failure or dysfunction because of less space, less compliance, and thickness, hypertrophy. Now, second reason, reduced chamber volume. Same thing like this one. So compliance and chamber volume, you can see from the picture, less space, less compliance. That's your second reason. That means your heart, when it's relaxing, it doesn't have enough space for the blood to like go and relax. So you have diastolic dysfunction. The third thing is you have less volume to begin with, so reduced preload from up from left atrium. So if you have less blood coming in, that means your heart, when it's relaxing, it has less volume, like it's relaxing with lesser volume, right? So it's diastolic dysfunction. That can happen when you have mitral valve stenosis. So mitral valve is between the atria and the ventricle. So when it's stenosed, the blood is like cannot come in, right, in the ventricle as much. So same thing as saying less space in ventricle, less blood coming in from because of mitral stenosis. That means you have diastolic dysfunction. All of these reasons, the heart is not able to relax properly with the adequate amount of blood. Okay, so I hope this is clear because we're almost. I think we have one more concept. So cardiogenic shock can be divided into four. You have left heart failure, right heart failure, systolic, diastolic dysfunction. Okay. We'll go to cardiac index, which is kind of like the last topic. This is separate from shock. This is a way to measure kind of the shock, if someone has shock. How? By measuring cardiac output. So you guys know, I think, BMI, right? So BMI is body mass index. We compare weight to everyone's height so that it's equal for everyone else. Cardiac index, we're doing the same exact thing. To compare if someone had more cardiac output than someone else, we have to put it under their body surface area. So we have to compare it to something of the person, because they might be tall, they might be short, like they might be very thin. So this all affects your cardiac index, how well a heart is working, how well your heart is working. Now cardiac wait, your heart is working. Okay, here. So now cardiac output, you just put that over body surface area of any person, and you can get their cardiac index, compare it to someone else, and then you can see whether they have less, whether they have more. Now the normal range for cardiac index is this. I used to memorize it as like 5, so it's easier, right? So whenever I see it closer to 5, I can tell that, oh, this is a normal cardiac index in this range. For the exam, I think just memorize the formula. I think you'll be fine. And if it's less, just know that if it's less than 1.8, that means your heart is not working very well. Your heart is failing because of less cardiac index. And that means cardiogenic shock, like what we mentioned before. Okay. So is there any question? I just have 2 questions, and I'll try to cover them now with you guys. And that's it. But do you have any questions for the lecture so far? Or is everything clear? Okay. I hope everything's clear. Um, because if not, you can always like ask me. It's fine. I can repeat. So these are from your lecture. These are summaries for left heart failure. You can see here one thing that he didn't mention before in the other slides is having dilated hypertrophy. So because of the pooling, because of all this pooling and here pooling in right ventricle, left ventricle, you have enlargement again. So that means in ventricles you can undergo eccentric or dilated hypertrophy, enlarged ventricle space. So that can cause S3 heart sound and left axis deviation on your ECG. You can see that for someone who has heart failure. Left atrial enlargement, like we said, for left heart failure, and pulmonary edema is one of the greatest signs that you can have. Right heart failure, you can have shortness of breath due to fatigue, like less cardiac output, sometimes, okay? Because sometimes lung failure can cause right-sided heart failure. So here, if lungs are not working, it can backflow and cause right-sided. But in like in other cases, it's not like for CVP, we're just going to say right ventricular heart failure because the right ventricular, the side is not working. So if the cause is the lungs, you can have dyspnea, but again, you don't have pulmonary edema. You don't have in right heart failure. That's the differentiating point. right heart failure can present with increased jugular venous pressure and a lot of these symptoms like peripheral edema, hepatomegaly. All these liver enzymes are up because your liver is now congested. It's not working very well. And this is again the same thing, dilated hypertrophy of the right ventricle because of the pooling. You have S3 heart sound because of volume overload, a lot of pooling, and right axis deviation. That's, you can differentiate that from the ECG. This is a summary of all the shocks that he gave. You have cardiogenic, we mentioned hypovolemic, we mentioned. Main thing for shock that they decrease MAP, right? MAP, you can, and then they can cause left organ, like blood flow to all your organs. So less MAP means that your body tries to compensate first. So I would add here, for example, here compensate. If it gets worse, decompensated. And then if that gets worse, you go into irreversible shock, which means death. That's it. So shock is very fatal. It's very dangerous. Okay, I think that's all, like, for the explanation part. I just have two questions. You guys can answer them. So first question, examination of a patient in supine position reveals distended jugular veins, right? This finding indicates which of the following: decreased venous return, increased central venous pressure, increased pulmonary artery capillary pressure, or left-sided heart failure. Do you guys want to? Oh, so these are like, you can try if you want. Okay, good. So the answer is B. Okay, and I'll explain it for the sake of whoever's watching the recording. So distended jugular veins means that you have increased central, that's the only explanation actually. So increased central venous pressure in your venous side, right? They can go up to your veins when you're lying down, and that's why you have distended veins. So you can see that on a person. Decreased venous return, no, because that wouldn't cause like it kind of like, it's not going back to the heart, right? But this one, increased pressure in the veins, means that there's more blood in the venous side, and it kind of like, it's a finding if you have distended jugular veins. Pulmonary, left-sided and pulmonary, not always, because again, like I said, it's sometimes that they can cause right heart failure, but it's not always the case. Like increased central venous pressure is always correct in this case. Okay, so last question. A patient presented with sudden pain in his chest and shortness of breath. He experienced difficulty swallowing, shortness of breath again, and then examination of patient shows fine crackles on lung auscultation and mild peripheral edema. What is your most probable diagnosis at this point? Is it right heart failure, interstitial lung disease, asthma, or left heart failure? Okay, someone said A. Okay, both of you said A. So again, remember what I said. So the correct answer here is D. It's fine though, like it's because this is a place you can all learn. So I'll try to explain why D. So and let me know if you get it or not. So again, remember what I said. In left heart failure, you will always have pulmonary edema symptoms, which means shortness of breath. And I know I said right heart failure also, but yeah, I should have added here, for example, shortness of breath, or like having difficulty coughing, like everything for pulmonary edema symptoms. Another symptom of left heart failure is difficulty swallowing. Why? Because remember what I said, left heart failure means left ventricle is not working, which means left atrial enlargement, right? It enlarges and compresses on the esophagus, which is behind your heart. It compresses on that, and the person has difficulty swallowing. So that's like whenever they're eating, let's say. And then fatigue, that's for decreased cardiac output with both heart failures. That's right. Mild peripheral edema, okay, that's fine too. So in left heart failure, sometimes it can cause edema. I know it's a very confusing point, but remember what I said, like left heart failure can cause right heart failure. So you can see right-sided symptoms sometimes with the left failure, left side. Again, let's Okay, let's go back here. So another symptom of pulmonary edema is crackles on lung. So you have lung abnormalities on examination of the patient. So that means you have pulmonary edema with left-sided heart failure. Again, this one could be because it can cause backflow into the right side. But main differentiating point is you have lung symptoms a lot and difficulty swallowing. That's like your main uh, like differentiators between right and left. So right, you would not have lung symptoms. You would not have lung symptoms. You would not have difficulty symptoms, swallowing symptoms, difficulty swallowing symptoms. You could have edema, and it would be very obvious. Like not, it wouldn't be mild. Is that clear? Like why the answer is left heart failure? I just want to know if it's okay. Good. So that's it. Okay. I know there's the two of you, but if you can please scan this code for it will only take 1 minute, because I just it's better for future sessions if we want to improve. So yeah, thank you for staying and listening, and I hope that was clear, inshallah. And let me know if you have any questions anytime. Like feel free to reach out to me.